All right. Hey guys, thank you so much for coming to UTD AMSA's first general meeting for the fall of 2020, our first virtual meeting. So kind of exciting, kind of bittersweet. So we'll go ahead and get started. And if you guys have any friends that are interested in coming, just pass the link to them so they can join before we get started too. So we'll go ahead and get started with officer introductions. So I'm Sneha. I'm one of your guys' co-presidents for this year, and I am a senior majoring in neuroscience.
Hi everyone, my name is Stephanie. I am also a senior majoring in neuroscience. I work along with Sneha as your co-president.
Hi everyone, I'm Shruti. I'm going to be the treasurer. I'm a senior neuroscience major as well.
Hi guys, my name is Ariba. I'm also a neuroscience major, but I'm a sophomore.
Hi everyone, I'm Lakit. I'm another neuroscience major and I'm also a sophomore.
Hi guys, I'm Avirat. I'm also a sophomore, but I am a political economy major.
Hi everyone, I'm Lane. I'm a sophomore biology major. My mic was muted a second ago.
Hi everyone, my name is Pooja, and I don't think Alex is on the call, so I'll introduce him as well. We're both advisors for AMSA this year, and we're both seniors as well. I'm a neuroscience major, and he's a bio major.
Alrighty, so what is AMSA? Basically, our club is one of the many pre-med clubs on campus, but what makes us different is that we don't have hour or GPA requirements or dues. So really with this club, with the beauty of AMSA is that you can get whatever you put into it. So we have all of these opportunities for you guys throughout the semester and throughout the school year. It is up to you whether you want to take up on those opportunities. This is just stuff that we want to share with you to help you out with your pre-med journey. So we are centered on volunteering, so medical and non-medical volunteering opportunities, pre-health track guidance, so we help guide you along on the way to medical school, how to prepare yourself in your pre-med years and what to expect when it comes to applications, MCATs and everything and above. We don't know about shadowing too much right now, of course, with COVID going down, but maybe in the future we may have some opportunities along the way. As well as some other discussions such as medical ethics, current events regarding healthcare news, and other important and relevant things. There is a national version of AMSA. This is just the local chapter version at UT Dallas. The national organization, you do have to pay a membership. You don't have to be a national member to be a member of UT Dallas AMSA member, but if you want to get the national perks, it's $75 for 4 years as a pre-med student. The beauty of doing this membership though at the national level is that it actually follows you throughout pre-med and med school, and I believe even residency. So what that means is that you can get more and more perks as you go up into your professional career path. So you don't just get benefits from joining AMSA at this level, but even as you go into medical school, which is pretty cool. That includes things like scholarships, conventions, and discounts you can get through the national level, as well as exclusive Kaplan resources. So we have some benefits as well as a MCAT study guide through some virtual speakers and MCAT workshops. All right. So another thing that we're starting to do this year is getting involved with the National AMSA advocacy initiatives. So an integral component of the founding of AMSA back in the 50s was the emphasis on advocacy at the student level. So for one thing, I just wanted to give an example of what's going on at the national level this month specifically. It's suicide prevention awareness. So there's some programming at the national level. I did add a hyperlink, and you guys will get access to these slides afterwards. You can click on that hyperlink to wellness resources that are put together by the action committee at the national level. So that's really cool to see. There's also some different action committees, as I have added a picture at the bottom there. These are all committees kind of created by chapters throughout the whole nation, all part of AMSA. So it's really neat to see what they do in terms of toolkits, advocacy, call-ins, calling your representatives. All of those things are just really interesting resources and opportunities to get involved with if you are interested in that. So we might get more involved in this as the year goes on. So if there is a specific initiative that you see on the screen here that you're passionate about, just let us know, because we could have a whole chapter-wide advocacy initiative to take place in. So that's pretty cool. Next slide, please. All right, so this is just some extra instructions. If you are interested in becoming a national member, again, it's not required to be a UTD member. We do not have any dues. We don't have any requirements. This is just to get those extra benefits that I talked about, as well as like access to different programs at the national level and some other conventions. So on the screen here, I'm not going to go into it very much detail, but that is how to become a national AMSA member.
All right, guys. So speaking of initiatives, I guess this is something that we've been doing as kind of like an annual event as part of UTD AMSA, and these are Blossom Parties. So if we didn't have this whole pandemic situation going on, what we would have done at least once a semester is host a Blossom Party, which is essentially using these kind of petals and other accessories that we were provided from Blossom Hope organization to kind of make headbands for pediatric cancer patients. And we go ahead and have those delivered to pediatric oncology departments just to kind of make any part of their day better in the sense. So if plans do change or we do find a way to virtually accommodate to our current situation and we're able to do these, we will let you guys know. But as of now, we're kind of putting this event on a hold, but we just want to let you know what would usually happen. So going on from there, as the majority of you guys are probably here for, we have our guest speaker, Dr. Devin Trousdale, here to speak to us about the evolution of medicine and how COVID has affected current practices and in general, you know, what the journey of a medical professional is. So Dr. Trousdale is a anesthesiology and pain management specialist, and he works in the Parkland, UT Southwestern area. So Dr. Trousdale, if you want to take it from here, I'll go ahead and stop sharing my screen.
Sure. Thank you for the introduction. Can everybody hear me okay? So you can hear me?
Yeah, we can hear you.
Okay. So I thought I would do something a little different in light of the current situation. So usually I speak to UT Dallas. This is my second year to do that, and I speak to TAMS every year if you're familiar with TAMS. Usually I just give this talk where I talk about like the basics, right? Like what internship, what residency is, just kind of a primer, right? So I thought with the current COVID pandemic, what I would do instead is do something a little bit differently and talk about sort of how medicine has changed since when I applied. And then kind of finish out with how COVID has affected that and affected our daily life and daily work life at Parkland, which I think is really illustrative of how everybody's affected. Because I talk to anesthesiologists around the country and around the world, and certainly what I see at Parkland is not unique. I won't say a whole lot of things specific about Parkland other than like publicly available information, just because everything has to be kind of vetted by them. So. But I can speak fairly freely about, you know, my daily life and that sort of thing. So very briefly, I went to college at TAMS, started at TAMS in 1991, was there for 2 years, it's a 2-year program. Then went to Austin College for 3 years and graduated Austin College in 1996. Got accepted to medical school, but I deferred it for a year to travel on a Thomas J. Watson fellowship. So I got to travel all over South America for about a year and a half, actually, because my last semester in college was in Mexico. Started medical school in 1997 at UTB Galveston, then did anesthesia residency at Parkland, did a cardiothoracic fellowship, and I was in private practice for 10 years. So I've been back at Parkland as a faculty anesthesiologist for the past 5 years. So that's me. So what I'd like to do is just kind of talk about how medicine has changed. And for the most part, it's changed in good ways as far as what you experience as a student, the technology and that sort of thing. There's a few areas where I think we've kind of swung the other way, which I'll mention briefly. But the biggest thing was when I applied to medical school, I just looked in Texas. And when I interviewed at UT Houston, this is in 1990, I guess it would have been fall of 1995, they made an announcement. They said UT Houston was the first school to break 50% on women applicants meaning out of the entire country, it was the first medical school, was what they told me at the time, ever to be greater than 50%. And I think that was applicants. I don't know if that was accepted, but I'm pretty sure they accepted greater than 50% too, because when schools have greater than 50% women, they tend to accept those too. So in my mind, so I went to school, kind of tucked that away, went into training. So when I was preparing this talk, in my mind, I assumed, okay, that trend probably continued. And what was interesting about the data is if you look at it for Texas and nationally, for so many applicants, you'd think it'd be pretty stable data, but it's gone up and down from year to year. So people base their decision on whether to go to medical school or law school or business school and so many different factors. So I was a little disappointed to learn that, it broke 50% that went down. But the general trend is that more and more women are getting accepted into medical school. And when they get accepted, they matriculate. So they actually have a higher matriculate slightly than men. Also, that's true for ethnic minorities. So if you look broadly at survey data at doctors, so doctors covers everybody, right? From intern all the way to people over 65. So if you survey and look at doctors over 65, they do outnumber female doctors by 64 to 36%. That's everybody. That includes my parents' generation. However, if you look at younger than 35 years of age, it's flipped. So there's more women that are entering medical school, graduating medical school, going through residency, and becoming doctors. So that's really good news. The specialties still lag behind. So, for example, the current rate for orthopedic surgery is 85% male, which I was actually surprised it was that low. I thought it was like 95%. In 10 years, I worked with one orthopedic surgeon who was female. But the trend is in the right direction. So there are a few specialties that kind of lag behind and that are still greatly underrepresented by women. There is a handful of specialties that are actually overrepresented by women. So obstetrics and gynecology, pediatrics, which if you asked me the top two, I would guess those. I would not guess allergy and immunology. I would have thought dermatology too, because all the students that went into dermatology that I knew were women. So those are kind of the numbers now. The same trend is true for African Americans. So there was a decline for a while, but it's gone up 4% for African Americans overall and over 7% for African American men. And what I can tell you is when I left Parkland in 2007, and then I came back 10 years later, essentially, I kind of have this like Rip Van Winkle experience where like all these things changed. And what I immediately noticed was that from the students to the residents to the faculty, there's so much greater representation. I think it just makes it a much better experience. There are certain specialties that I never saw women, like in vascular surgery, for example, and I probably work with just as many women as I do men. So that's all really good news. And then Texas, that's nationally. So Texas, for the first time in many, many years, again, because it's an up and down trend, 2 years ago, they broke greater than 50%. So they had 50.9% applicants, but they also matriculated 51.6. So when they accept women, women tend to graduate by a slightly higher margin. So that's all very good news. So that's a general trend. That's nationally, that's Texas. The other thing that's really changed a lot, and it's definitely changed from generation to generation. So if you talk to the older generation, when I was in medical school versus mine versus your younger generation, I think medicine is a much more pleasant place to work. I certainly in my generation have witnessed abusive behavior. I was at a surgery program in New York, in the Bronx, that was abusive, just the way that we were treated and other people were treated. This is actually a topic that I lecture about every month to the medical students. So I know a lot about this. I actually gave a talk to the TSA, the Texas Society of Anesthesiologists, about disruptive behavior. So the kind of just outrageous abusive behavior that was common and accepted back then is becoming less and less prominent, which is great. So I think when you do get accepted to medical school, it's going to be a much more welcoming environment. Now, if you look at when people compare generations, they complain about your generation. So there's all these things that they say about millennials and Gen Z, and but what I've noticed is that I enjoy working with younger people because I feel like for all the flaws that are highlighted by the media at times, which every generation has its complaint. The older generation always complains about the younger generation. The thing that I do like about your generation is that you guys are much more likely to be collaborative and work in a team environment, and I see that every day. So when I trained, the anesthesiologists and the surgeons barely talk to each other. It's very hostile at times. And it's just wonderful now to start each day and the surgeon is talking to me, I'm talking to them, we come up with a plan. It's just more cordial. So that's been great. The things that have gotten kind of better and they got worse and are kind of getting better and worse again are the work hours. So I got really lucky. I was a very competitive applicant for anesthesia, but the time I applied, it was actually not a very competitive specialty. So you could get into some pretty good programs and be an average student. I was above average on my boards and that sort of thing. Now it's extremely competitive. But I got lucky in another way, which is we had what were called the ACGME work hours, meaning we couldn't work more than 80 hours a week. You couldn't work more than 24 hours at a time. And that was kind of how things worked for about 20 years. Now, I was at a surgery program that just violated those hours. But when I came to Parkland for anesthesia, they adhered to it like a team. So the problem with that, so that was great because 80 hours sounds like a lot, and it is. I worked 100 hours a week, and that's not fun. It's not good for patients, and I don't think it's even that great for education. They said it was for education, but it was really because the cheap labor. So what's changed since then, though, is that the programs kind of had a backlash against that, and they said, look, we don't like surgery residents to be, at their 24th hour, they're basically just clocking out and leaving in the middle of a case. And that was kind of odd to witness. Is you could be closing a surgeon and be like, or closing a patient, and they're like, okay, you got to leave. So they felt like that was to the detriment of the training. So now what the ACGME does is they've kind of gone the other way a little bit and said, these are more guidelines. And, if you're in the middle of a task or certainly in the middle of a surgery, you're expected to finish that. I hope that that's a healthy blend because I've definitely seen programs abuse that. So I see both sides to it. But what I would say is the whole reason why this came about. Well, are any of y'all familiar with Libby Zion? Does that sound familiar? Okay, so I'll give you guys a reading assignment. So read Libby Zion. You can just go to the Wikipedia page. It's a rabbit hole that you can spend hours reading about. But she was basically this young patient about your age. She came into the ER. She had some kind of perhaps viral illness, and she died within about 12 hours. Now, her death was probably completely unavoidable, but her death was blamed on the fact that the resident and intern that saw her had worked in excess of kind of normal hours. And that became what was known as the Bell Commission. That's what created the ACGME work hour limits. Now, her death probably had nothing to do with the work hour limits, but it set in motion some really good reforms. And this is all based on data that showed, for example, we have data from the military that shows that after 24 hours of not sleeping, if you're involved in a simulation scenario, you start shooting your friends, like you just can't think straight. And so I hope that the pendulum hasn't swung too far the other way. So I can't promise what you're going to experience as an intern or resident. I don't think it'll be abusive. I think those hours will be generally respected, but it will be very specialty specific. So that's the latest. Now, the downside, I mentioned, for the most part, the technology, the EHRs, I complain about EHRs all the time, electronic health records, but they've really made my job easier because I can have all this information at my fingertips. So there are some great changes in technology, safety, and that sort of thing. But where I think we swung the other way is that we used to give residents and even medical students quite a lot of autonomy. I tell my younger colleagues things that they can't even believe. When I was a medical student on the obstetrics rotation, as a medical student, I was allowed to do tubal ligations in patients, meaning, tying fallopian tubes. And the attending surgeon would start it with me, and then as I got started, he would go to the other side and start dictating. And people are just appalled when I tell them that, the younger faculty, that they gave that much responsibility to a student. When I was on my surgery rotation, my second-year resident said, by the end of this rotation, you as a medical student, not an intern or resident, but as a medical student, you should be able to do an appendectomy from beginning to end. Now we don't give the students that kind of responsibility. We don't even let them write notes in the chart. So I think we've gone the other way, which is we focus so much on education and less on the practical side with this idea for safety, because we don't want patients to be, experimented upon by inexperienced students. That I think that your education suffers because of that, because there's a first time for everything. If it's properly supervised, I think we can give residents and interns and even students quite a lot of responsibilities. That's kind of my old man soapbox. That's out of all the great things that have happened in medicine, the changes in gender and ethnic applicants, minorities. That's the one thing I feel like we're failing the students. And COVID is certainly a unique situation. For almost 6 months, we were not letting the medical students anywhere near. They weren't even coming to the hospital. we've gotten to where if a patient is HIV positive or Hep C positive, which is a lot of our patients, they're not allowed to scrub in for surgery. And I scrubbed in plenty of those surgeries when I was a medical student, and I feel like it really discounts the value of that education for you. I know that COVID is a new novel disease and there's not a cure per se, but you're fairly young and healthy, and certainly it's not a 0% risk, but I feel like it's a risk worth taking. Practically what that means is I have a pre-med program that I have for pre-med students where I let college students shadow with me. I've done that for the past 4 years, and that's on hold for now. And I feel like it's a disservice to you because we can't pause everything. We can't, I mean, we have a whole new generation of people that we need to educate. So that's my soapbox. Okay. So that's how medicine has changed. I think it's changed for the better. I think you're gonna have an exciting career if you go into medicine. So let's talk about COVID. So I wrote a Word file, and I can share it with Sneha to distribute it, but I created a Word file for non-medical people that I've shared with my family and friends that kind of summarizes the best available data with links on COVID. So I'll send that to Sneha so y'all can have that. So this kind of comes from that. So the first thing I talk about, and I think this is what impacts people the most when I talk about COVID, is that this is a big deal, but we're not suffering alone. It's a big deal for you as college students. It's a big deal for us physicians, as nurses, as parents that are trying to educate our children. Literally everybody in the world is affected in some way. And the last time we had anything like this was 100 years ago. So it's a once in a lifetime thing. You'll have something to tell your grandkids. However, I think we need to have some perspective. Some of you may be first generation Americans where you may have grown up in a country where, you know, there was tremendous amount of stress that average day Americans don't experience. And what I can tell you is that if you talk to some of the older, like the CRNAs I work with that grew up in the 80s around the HIV/AIDS crisis, this was their COVID. So there are subgroups of people, population groups of people, of patients and that sort of thing that went through pretty much what we're going through, but worse. So if you were, you know, LGBTQ in the 80s, you personally knew lots of people that died in front of you. My dad was a nurse. He went to nursing school in the 90s, and I remember visiting him on wards, and we just had entire wards of people that were dying of AIDS. We didn't have a treatment for it. And that was in the late 80s, early 90s. Same thing for Ebola. You know, for certain areas of West Africa, what they experienced was, you know, worse than what we're going through. So I think it's important to have perspective. The other thing to keep in mind is that as bad as COVID is, which it is, it's still nothing and probably never going to be anything like the 1918 flu pandemic. There's a great book on that. I'm blanking on the title, but I'll send a link. There's a few books, but it's a book that was written about 15 years ago. The 1918 flu pandemic was so powerful that it lowered average life expectancy by 11 years for that year. So it was unique in that it hit people in their prime. So it mainly affected people from age 25 to 44. So we're talking people that were like 26 years old, which back then that meant they were parents and had kids and they were starting their careers and all that. They died. And what was crazy about the flu pandemic is that it was so quick. So there's a saying, they said that you could be well on Friday, get sick on Saturday, and die on Sunday. So COVID is not like that, right? There's a 5 to 10 day or more sometimes window. So what I'll provide, and it's in my outline, but I'll make sure you guys have that available, is I try to share information that I find is helpful. I will tell you during that 2 weeks that I was on my staycation where we were sheltering in place, I became very depressed. It was kind of sad to see all these things happen around the country and around the world. And I could only feel that way for so long. And so what I did was I created an email file because I save everything by email files. And anytime there was an article that was not positive in the sense that it was pie in the sky, anything that looked positive and was likely true, because people shared a lot of stuff back then, I would save it. And I was also, as a physician, I'm the only physician in my family, I was very reluctant to share anything with my family or friends that promised too much, right? But the other thing I didn't do is that I'd never shared something that was negative just for the sake of a headline grab, because I realized pretty early on that there were some pretty scary headlines that if you actually read the article, it didn't really deliver on what it said. So for example, there was one article that said the Princess Diamond cruise ship, they found viral particles up to 17 days after exposure. Well, if you read the article, it says these are not infectious particles. But most people probably shared that article, panicked, thinking like this thing could be on, you know, my mail for 17 days. And so I purposely would not share things like that I felt like did not contribute to the overall knowledge. So I will tell you what I watched, and what for me was a turning point and just helped me to feel more optimistic was every week my wife and I watched the UCSF Grand Rounds. So are any of y'all familiar with that? It's so their internal medicine department. So first of all, UCSF, they have the best anesthesia program in the country. They probably have the best infectious disease, the best critical care. But they're also have one other thing that's important about UCSF is that they were at the epicenter of the HIV/AIDS crisis. So these people know what they're doing, and a lot of the physicians and scientists that speak on these grand rounds, they were there in the thick of it. So they've applied a lot of that kind of thinking and knowledge to COVID, and it's good to kind of have that long-term perspective. I think people should be very mindful of what they see and share on social media. So for me, the UCSF Grand Rounds are invaluable. It's about an hour and a half. You don't have to be a physician or in medicine to understand it. My wife's a CPA, and she watches it with me, and she gets most of it too. So I talked a little bit about myths and misconceptions. There was a question in the Google Doc. I didn't touch on it, but I just wanted to mention it. It was something about basically the anti-science attitude that we have in anti-vax. Our country's always been that way. So that's nothing new. But what I would say is what we also have to do to keep perspective about COVID is that we have learned more in the past 9 to 10 months than what took us years for HIV, what took us years for Ebola. So we have to have a little grace in that sense. It means that information goes back and forth, and what seems true one week is not true the other. So be very mindful of information that hasn't really been vetted. And that's why I like the UCSF Grand Rounds, because it kind of has to go through a few filters. But I'll give you a clinical example of when I was a medical student, and this is something you deal with as a physician. And kind of, for me, it's a microcosm of how our country operates sometimes. So when I was a medical student on internal medicine, this is at Brackenridge, which was the community hospital for Austin. It's not around anymore, I don't believe. We had a patient that was admitted, elderly patient with pneumonia, lobar pneumonia. That part of her lungs whited out. We treat the pneumonia successfully with antibiotics. And then as that pneumonia clears, we do a repeat C-section. We find out that her lung, that lobe actually had cancer as well. So we tell the daughter, and this mother's on a ventilator, we tell the daughter, we have some good news and bad news. That the pneumonia is successfully treated and she appears to be getting better, but she does have lung cancer. Well, to the daughter, that meant we didn't know what we were doing. You told me it was pneumonia, now you told me it's lung cancer. She was emotionally upset just because of what was going through with her mother. But I've seen this over and over again with patients. We had a maternal death last year that I was involved in. We have one about every 2 years at Parkland. It's very rare for a woman to die during pregnancy and delivery, but this woman did. And we did not have all the data. We suspected what it was a pulmonary embolus, amniotic embolus. But the initial autopsy data didn't tell us that, and we knew we had to send out for the slides or whatever, and that would take weeks. So here we had to tell the entire family. So imagine meeting an entire family, extended family, people, grandparents, everybody, and say, we think it's this, but we're not quite sure. Well, to them, it just meant that we either didn't know what we were doing or we were lying. And so when I think about the public, and I know you guys are frustrated at times with the back and forth on information on masks and that sort of thing, the public is kind of that patient, right? That family that, to them, it seems like the scientists don't know what they're doing. I think you guys are smart enough to understand that. But just keep that in mind when you're talking to family, because you may be the only, future doctor in your family, and you're trying to interpret those things to them that just have some perspective and grace and realize that they're frustrated, right? But we are learning more and more about this. Now, my biggest concern, and what really made me the most sad when I was in our shelter in place, was I thought we were going to end up like Bergamo in northern Italy, because I didn't see us taking any real precautions. And if you're not familiar, northern Italy just got swamped. They got swamped because they were early before they knew it, just like New York City did. By the time New York City knew they had a problem, it was on top of them. So what I can say about Parkland was that sometime in March, we radically changed our hospital. We took nearly all of our operating rooms and converted them to a makeshift dedicated ICU for COVID. All patients, all acuities. Now, if they were not sick, then they went to a special COVID floor. But if they were sick at all and needed oxygen, they went to the COVID unit. This had profound effects over daily operations. It meant that there are certain elective procedures that we do that we're still not able to do. And so what I would tell anyone outside of Parkland, I see these things in our neighborhood Facebook group and these sort of things that claim that it's over, or that it was overplayed or whatever. I promise you it's not overplayed. It's had a profound effect on what we do. Now, as far as my daily life, I mentioned earlier to the officers here that my daily life has changed in that it was really stressful at first because we didn't have the PPE. We still don't have. We technically have the PPE as far as what you can wear, but I get 1 N95 mask every 2 weeks. So I've seen in the news where nurses are complaining and saying that they only give me one per day because they are supposed to be single use, right? You go and see a TB patient with your N95 in the old days, which was 6 months ago, you had to throw it away, and they would have screamed at you. Now we wear it for 2 weeks. So that's definitely changed a lot. So no matter what you see in the news, a lot of hospitals are, if they're not in an outright shortage, what they're basically doing is they don't want to start giving this stuff away like candy anymore because they don't want to get caught with their pants down. So, so in that sense, it's changed. What I can tell you emotionally, though, is that people just look beaten down. And by that, I mean the doctors and nurses I work with. We're working harder, longer than ever before. We are at a place now where we do have a better control over it. We have better pathways. We don't freak out every time we see that there's a COVID positive patient. So what's new? So I'm going to finish the talk by talking about, I'm going to kind of summarize everything that I know about COVID as far as where we're on testing, therapies, and that sort of thing. And then if we go through just the list of questions you sent me. So I'm a hopeless optimist. Like I always see the silver lining in everything. And that's sometimes frustrating for people because I can have it's a good thing. It's a defensive mechanism, but I can have a very sick vascular patient, this close from dying, and the surgeon asks me how the patient's doing, and I'm like, it's okay. It's okay. Yeah, we're going to be okay. That's usually my answer always is, it's okay. Yeah, we'll be okay. So where are we on testing? So PCR, if you're not familiar, is kind of the gold standard, and that's what we use at hospitals. And if you go through a drive-through, some of you may have had the brain biopsy. Has anyone been tested for PCR? You don't have to tell me if you don't want to. Has anyone been tested for COVID via PCR? The gold standard is a nasal swab that goes straight up your nose almost to your brain, and it's very unpleasant. Now, it's the gold standard because it's highly specific and highly sensitive, but it must be done in a kind of lab setting. It's so sensitive and specific, though, that it doesn't tell us where you are in the infection curve. So even if you're not infectious, you could be 2 months out from an infection, you may still test positive. So the future of testing is going to be antigen testing, which is not as sensitive. And you'll see in the media, I've even seen physicians say, well, it's a trash test because it doesn't catch every case. It doesn't need to catch every case. What the antigen test does, so PCR basically multiplies DNA, right? Meaning it can take a tiny DNA sample, no matter how infectious you are, and it can multiply through a chain reaction and tell if you're positive. Well, antigen testing just takes what you have. So the most common antigen tests now are saliva, meaning you just spit on a strip, just like a pregnancy test, where if you're positive, you're positive, you're negative, you're negative. Now, you could technically be infected by PCR, but not be infectious. So you could test negative on the antigen test, which means for that day alone, you're not infectious. So it's really an infectiousness test. So why is that good? Well, one thing, you don't have to stick a thing up someone's nose. That's kind of, nice. My 7-year-old had that done last year for the flu, by the way, and she will not let you near her with the swab. So it's very unpleasant. But what it means is we could get to some semblance back of our daily life. So if you went to go watch a movie or if you went to a restaurant, this is not an expensive test that requires a big machine. It's literally just a strip of paper. So you could spit on a piece of paper. You could technically be infected but not infectious, and you could go do that thing. You could go to school. You could go to in-person classes because you tested negative for that day. Now, who does this? One of the tests was developed by Yale. That's the test that the NBA uses every day. So they have 370 employees, players, staff, whatever, that are in this bubble at Disney. Every single day they test players. They have not had an outbreak. So it has to be done at least every 3 days to be effective. Once you get beyond 3 days, then you kind of miss that window. But I think the future is going to be cheap, rapid testing. Where are we on therapies? So if we're comparing this to the HIV/AIDS epidemic, remember how I said in the 80s and early 90s, we didn't really have any effective therapies. So you just kind of went to the hospital to die or be treated for the opportunistic infection you had. So you'd have, for example, pneumocystis carinii. So you'd have this pneumonia, and we could treat the pneumonia, but we couldn't treat the HIV. Well, now we treat HIV as an outpatient, right? We give you a set of pills, antiretrovirals. There's a drug called PrEP, which is given to people at risk. So those two classes of drugs alone have really stamped down the HIV epidemic. That's outpatient therapy. So I based on everything I've seen, I believe the future of COVID is going to be outpatient therapy. don't go to the hospital in the first place. How do we keep you from going to the hospital? There's a few promising therapies. So one thing I do want to say though about myths and misconceptions about COVID is that you may have seen this in social media and the news, which is there are people that believe that if we put you on a ventilator, you die. Like the ventilator is causing people's deaths. And what they said was, well, in New York City during their peak, 80% of people on ventilators died. What people took that to mean was, well, if we put you on the ventilator, it kills you. We only put people on the ventilator when they can't breathe. So let's be clear about that. What's changed though is that early in the pandemic, at our institution and at a number of places, we didn't have adequate protections in place for workers. So a principle of ventilatory respiratory management is that we try to use the least invasive method as possible. Well, if we don't have adequate PPE and we're concerned about that, we're probably not going to let you just sit there with a face mask. If you're showing signs of decompensation, we'll put you on the ventilator early. That was early in the pandemic. It made me very happy to see by late March or early April that the first time I had to work in the COVID unit, I saw rows of patients that had CPAP, high flow nasal cannula, basically these non-invasive ways of breathing, because you can be on that and temporize and never be on a ventilator. The ventilator does have its negative side effects, if you will. If these dogs get loud and my girls come here, I'm gonna have to go in the other room. So forgive me. So we've advanced that way. So how do we keep you from going to the hospital in the first place? The most promising drug right now is a drug called remdesivir. It's an antiviral, and we know that it works. The study that you've probably read about showed that they gave it to hospitalized patients, right? Now, they said they didn't see a statistically significant drop in mortality, but there's a trend towards lower mortality. I don't know who that is. But the biggest finding was that the ICU stay went from an average of 14 days down to, or 15 days down to 11. That is significant, right? That's a 30% drop, almost 50% drop. However, what likely happened was remdesivir is an antiviral. We know that COVID works in two phases, right? There's the viral phase, and then by day 5 to 7, the virus goes away. Most people get better. The people that don't get better, it's because their immune system takes over. They have what's called cytokine storm. So given an antiviral, that like probably has no effect or very minimal effect. So the two drugs that are most effective now are remdesivir, which is antiviral. What we know about antivirals is that when they do work, the earlier you give them, I'm gonna have to go in the other room, sorry. The earlier you give them, the better, right? So we actually have a trial now at UT Southwestern that when you test positive through their drive-through, they send you over to this booth where you can enroll in the study. And what the study is it looks at, you have to have certain risk factors. So if you're over 60 and you have any comorbidity like high blood pressure or diabetes, then you can enroll in the study. And you'll receive, I think it's 2 doses of remdesivir. So remdesivir is IV only, but it's once a day dosing. Now you could say, how do you do outpatient therapy as an IV? We do that all the time with chemotherapy. So you would go to a clinic, they start an IV, give you the infusion, go home, come back the next day. So that looks really promising, and I think that's going to be the future. Steroids are very effective. However, they're only effective once you require oxygenation, because what steroids do is they treat inflammation and they help mitigate that cytokine storm. They're highly effective. But if you give it early, not only is it not helpful, but it's probably harmful. Someone is really trying to get into my house. If you'll excuse me, I gotta go see who this is. So sorry about that. So we know that that's effective. Give me like 2 seconds here. I think it's my daughters. I think they're locked out of the house. Okay. It's the greatness of Zoom meetings, right? Hey. Okay, we'll go find her. All right. Where did your sister go? No, she didn't know. Well, go find her. The door's unlocked. Sorry. Those are my 2 wonderful daughters that were on the intro page. So I'm very optimistic. And the question is, can you give it in pill form? The leading expert on remdesivir was asked this about 2 months ago, and they said it's probably technically feasible. So they're definitely going to look at it. The other option is given it in an inhaled form. So if we aerosolize it, we can give it that way. So that's also a trial that
think he might got frozen there a little bit.
All right, can you hear me again?
Yes, you're back on.
Okay. I'm gonna have to hide from my daughters. I don't know. Sorry about that. Anyway, so I'll just sit on the edge of my bed here. I think that's very promising. Inpatient care, I think the key is going to be keeping people from getting into the hospital and on oxygen in the first place. Vaccines, you know, that looks very promising. Whether it confers long-term immunity, we don't know. But we do know that after 9 to 10 months, 28 million people have tested positive, I think, for COVID-19. Or there's been almost 30 million cases. And there's only a few case reports of reinfection. So if there's a vaccine and it's effective, you know, it will probably, you know, potentially provide at least a year of immunity. Now, I have friends that look at that and they say, well, that's, you know, that means we're going to have to do it every year. That's still light years ahead of where we are. So again, I'm an optimist. And so that's better than what we have now. And then the last piece is on masking. The thing about masking is there's excellent data. There's more and more data. There's cruise ship. There's data comparing the Princess Diamond cruise ship and the cruise ship that left Argentina for Antarctica that found that masking is extremely effective, and you don't even have to have an N95 mask. So the idea is that with even a cloth mask, again, not an N95, not an N100 mask, that cloth masks are great at preventing disease. However, because they're not 100% effective, and viral load and inoculum are a significant factor with COVID, that you actually can get infected with COVID, but it's a small enough number of viral particles that you do not get the symptoms. So you get sort of a mild version of the disease, no symptoms, but you get all the immunity. So I feel very comfortable wearing just a mask out in public when I go grocery shopping. I can tell you that when I worked in the COVID unit, and I've taken care of a number of patients there, my N95 mask does not fit that well. In fact, the CRNA that I was working with, his N95 mask fits so poorly that his clear plastic face shield fogged up and he couldn't see what he was doing. So I had to kind of guide him. So we've had pretty poorly fitting masks, many of us, and we haven't gotten COVID, and we've been surrounded by COVID. I've been like literally in the face of COVID patients. So a few things I will leave you with is that I think there's a middle path. I felt like that since the beginning. I don't think quarantining the entire world is effective. I think with improved testing, with improved therapies, we can narrow that quarantine down, not just from 14, but to 10 days, but even further. If you tested positive by PCR, and for example, you had 2 negative sequential antigen tests, you're basically not infectious at that point. So I think that's the future. So it's going to be different. And again, the sort of silver linings of things, I always look kind of like the good at things. There's a few examples in history of when some crisis like this happened and some good things came out of it. And we're seeing a lot of that. So for example, in 1980, there was a subway strike in New York, and it was for many months. And women that had ridden the subway and wore heels couldn't ride the subway anymore. So now you have these women that are having to walk miles and miles to walk to get from home to work. They're not wearing heels. They were wearing either running shoes or flats. Well, when the subway strike went over, they didn't go back to wearing heels. So it was an opportunity for them to go to work without having to wear something really uncomfortable. And we're seeing that in medicine. So it sounds silly and petty, but in the intro cover where I'm wearing that cap, for the past few years, we've been banned from wearing any kind of cloth cap. We have to wear these like ridiculous paper disposable caps. And that comes from the AORN, the nursing, their organizing body. Well, now we have these cloth caps again, and we're probably not going to go back. And it's great. I like it because you can put your name on it. People can recognize you. People can be creative. It's depressing at times working in the hospital these days. And so it's just kind of have the conversation in the morning. It's like, oh, I like your cap. Where'd you get that? So it's just kind of a nice way to add something a little different to work. I think when this does get kind of stamped down, I think you guys may go back to in-person meetings. And I think in some ways there's no substitute for that. But I like the fact that I can give this talk from, well, aside from my dogs and my girls, I can give this talk from my laptop from my home, and I don't have to drive through traffic. I give lectures once a month to the medical students. I've done it from a hammock in my backyard. And I told our education director, I said, I'm never going to go back to in-person classes because for me to do a lecture, I usually have to drive to Parkland. It takes about 2.5 hours out of my day. I can only do it on my off days because I just don't have time during my clinical days. And it's been great. And so I think there are all these little ways that basically these things that we've been pushing for years, right? If you're a business, like think of all the conferences. Well, you guys don't see this as much, but I feel like my program wasted a lot of money on some of these conferences where you have to fly people hotel. I went to the ASA last year. I thought a lot of it was a waste of time and money. If I were a program director next year and things get better, I'm not going to pay to send all these people to a conference. I would try to arrange as much by Zoom and online and that sort of thing. I think that's about it. So I've got your, left it in my office. Let me get the list of questions. So I can go through the questions you posed on the Google Doc. How much, can you give me an idea of how much time, like what your usual time sequence is?
We have about like 10 to 15 minutes to spare, but
Okay.
before we hit up those questions, we actually have one in the chat.
Sure.
If you wouldn't mind one first.
Yeah.
So someone asked, how are medical schools adjusting their requirements and expectations for applicants due to COVID?
So I don't deal directly with the applications. I've done interviews. So I'm not the best person for that. I will say that for a period of time, I'm just going to go to my kids' little classroom here. So for a period of time, the clinical experience was kind of put on hold. So that's a question. So, do you have an additional question? So,
It seems like you were cut off a little bit.
Sure.
As you were entering the room. So I think if you could just repeat what you said, like just a couple of sentences you just said, I think we missed that part.
Sure. What part was it? Do you remember what the last thing
All I heard was you said that you were like, I'm not the best person that has the most information on it. I'm not sure if you said something.
Oh, I'm sorry. I just now. I'm sorry. I thought you'd been earlier. Yeah. So I'm not involved in the admissions side. I've done interviews. It's hard for me to say. The only thing I really know is what I see as faculty. And I know for a period of time, the clinical aspect was on pause. Like you couldn't go to the hospital and be around any patient, not just COVID patients, but any patients. So we are returning to some form of normalcy. So that's about all I know about that. Sorry. And then if you have additional questions, you can ask me. I have the questions you sent me through the Google Doc. I can go through those.
I actually have another question real
Sure.
quick. So I know a lot of college students coming back on campus have been depending a lot on COVID testing, especially the PCR test, to just make sure that they're negative or they're not, contagious or whatever. And I'm not sure how effective that is. I wanted to get your opinion on that.
So a few issues. One is that it's expensive. So I was listening to this interview yesterday on the drive home. It's the editor of the Journal of Higher Education. And it was a very broad, wide-ranging interview where he talked about these universities that have kind of failed. They blame the students for having parties, which students have parties, and the parents blame the universities. But in order to test, a school that has 40,000 people, it's $100 to $150 test. So I think one is whatever. I don't think that's going to be the future because it's just too expensive, right? And then the other problem with any test, you want to have good selection criteria, right? So ideally, you want to test people that have some kind of known exposure, maybe some symptoms. So if you're just blanket testing people as a screening test, it's a pretty poor test in that sense because you may be negative today, but then if you go to a grocery store, whatever, get an exposure, that basically negates all of that negative testing today, right? So I really do feel that PCR testing should be reserved for the people that need it also because the PCR requires reagents and we have a reagent shortage. So I'll just tell you, Parkland and in Dallas County, we're down to 50% on our PCR testing because the supplies that are necessary to do the PCR are in a shortage. Antigen testing doesn't have any of those problems. Like it uses saliva, and there's one I think that uses a machine, the Yale test. All it uses is heat. So these are extremely simple, cheap tests. So you're talking $100 to $150 versus a $1 to $15 test. So I don't think that's very effective because how often are you going to test yourself, right? I think the key is to do certain things that mitigate, and I think that's what we're seeing. So we know that I'm very confident that wearing masks, in certain environments, that wearing masks is extremely effective. I call it the 3 habits. So it's wearing a mask, hand hygiene, which people are just bad at hand hygiene anyway. You go into a men's restroom and walk out, like half the guys don't wash their hands. So that's got to end. And then social distancing when appropriate, right? So here's the thing about that. There may not be a flu season this year. So one of the biggest concerns people have is that we're going to hit with this double whammy of flu and COVID. All the things that we do to mitigate the flu, we're doing with, or that we don't do to mitigate the flu, right? We don't wear a mask normally. But all the things we're doing to mitigate COVID are probably going to reduce the transmission of the flu, right? So I think you cannot rely on PCR testing. Plus, here's a few things. Here's 2 other things I've noticed. One is if it takes 5 to 6 to 7 to 10 days, it's pretty useless, right? Because the clock starts all over again. If you have a positive or a negative test, it's not you're positive or negative up until the point you get the result. It's you were positive or negative on that day, right? So if it takes 7 to 10 days, it's almost completely useless as a surveillance tool. The other thing I've noticed, and I hope that you guys are too smart to do something like this, but I've seen it over and over again. My wife's company, my friends' in-laws. Unfortunately, we had a coworker, an employee that did this, is when people have an exposure or they have symptoms and they get tested, what would you do? Sneha, you'd probably stay at home in quarantine until you got the results, right? Because you're smart and you care about people. But what most people do, I don't know about most people, what too many people do is they go about their daily business until they get that result. So one of my good friends from college, his sister-in-law was feeling sick. She had really high fevers. Turned out it wasn't COVID. People get fevers for other reasons. But for the 5 to 6 days that she was waiting on her test results, she went about her daily life as usual. She and her husband were looking at homes. So they're going from homes to homes to homes to buy. This is completely reckless behavior, but that's what a lot of people do, is they don't realize that the test is positive on the day they take it, not the day you get the result. And we've even we've seen companies where the employers tell the employees, don't call in sick. Basically, don't tell us until your test results back. You show up to work, even with symptoms, or if you're asymptomatic. 40% are asymptomatic. So telling people to come in because you're asymptomatic is it's crazy. But there is a psychology to this, and I've noticed it over and over again. I think you all as pre-med students understand that. But just today, actually, there was a case of a student in Massachusetts that the kid tested positive. The parents knew it. They sent him to school anyway. That's actually it's even worse. But so there's a social side to everything, right?
Right.
I will say this though. Again, I'm an optimist. My dad lives in a small town, and the small towns kind of blew this off. I travel through small towns to go see my dad, and I've noticed more and more and more that people are wearing masks, and the kind of people that weren't wearing masks, as in my dad's generation, the boomers, if you will. You walk into a restaurant, which we would do takeout. You go to a restaurant to pick up takeout, the waitresses, the customers are wearing a mask. 2 boomers walk in, no mask. Not as in like they had it and took it off. They don't even have a mask. They just walk in and sit down like it's nothing. So I think that behavior is slowly changing. Now, where the UCSF experience I think is so vital is these people did deal with the HIV/AIDS epidemic, and what they said is we shouldn't be fining and jailing people for not wearing a mask. We shouldn't be shaming people for not wearing a mask. We should use carrots, not sticks, because that's what worked with the HIV epidemic. We told people how to have safe sex. We didn't tell them not to have sex. And so whether or not you agree with this or with the behavior or with the practice, you have to meet people halfway. And that's very hard to say as a doctor because, well, not for me, because I deal with vascular patients and they don't listen to anything we say. So I'm used to it. But it's frustrating just as a person seeing people do really risky things and expose themselves.
Oh, yeah. I think Stephanie had a question to ask as well.
Yes, so thank you so much for talking to us today, Dr. Trousdale. I want to ask if you have any advice for people like us who are just starting our medical paths as undergrad students, and what advice you might have for us as we go into our medical journey as well as a physician.
So I was thinking about this. The first thing I've always told people for years is keep an open mind, right? So I thought I was going to do family medicine until I actually did it, and I realized I didn't like it. I actually found out about anesthesia because I promise it was not on my radar at all. But one of my friends worked as an anesthesia tech at night. So UTB Galveston had this thing where they employed medical students to work from 6 p.m. to midnight as an anesthesia tech. I did it because it paid $7 an hour, and I just wanted extra money. That's how I found out about anesthesia. So it was a lot of money back then, I guess. But so one is keep an open mind. The second thing, and actually the reason why I was in my office is I was going to maybe take a moment to show my books in my office. I like to read history. And one thing I will say is no matter how busy I was as a medical student, no matter how just beaten down I was as an intern, I've always found time to read. And my thing is nonfiction. Like I like to read U.S. history and world history. So my bookshelves are just covered. Like I did this project, I think I started a few years ago, where I was going to read a biography of every single president. And some presidents I did 4. So I'm just on FDR again. This is my second round. But anyway, that's very relaxing to me. The other thing I did was, again, even when I was a busy intern, is I would sit down and make dinner, make a meal, right? A healthy dinner or whatever. To me, that's really relaxing. So the times that I'm most stressed out, which is the times that people tend to do the least, right? Like you're stressed out, you don't have time. That's when people eat like McDonald's and stuff, right? Well, I do the opposite. And so when I come home and I've worked till 7, I've worked late and I've had a long day. The most relaxing thing for me to do is to take time and cook for myself, my wife, my daughters. So that's probably the biggest piece of advice. I know it's not specific, like do this, get this MCAT score. The other thing I will tell you is the first time I took a practice MCAT, so I was going to apply in the fall. I took a course in the spring. I didn't feel like I learned anything in the spring. And then I was kind of getting worried. So I went from worried, am I going to get a decent score? My practice results were not very good. And then I got really lucky. Both of them were Kaplan courses. So the first one was just a medical student that taught the course. He wasn't very good. And then in the summer, I had this grad student that when I say he taught, I actually learned physics and I learned these topics that I didn't really learn the first time. I just passed the test. And so I actually learned principles of physics. I actually learned the material, and it's still with me today. So if you are going to study, when you do study for the MCAT, learn the material. If the course isn't working out for you or whatever, don't get discouraged, right? Don't take it until you're ready. So fast forward to when I took it that August, I felt so confident about it that when I walked out, I actually finished a little early, and I was like, I feel great. And I ended up getting a really good score. So it was a lot of preparation. I spent a lot of time preparing for it, just like I did for my boards. I probably spent more than anybody I know preparing for my anesthesia boards, but I wanted to pass it the first time. So that's the biggest piece of advice I would give you just in general.
Thank you very much. That's really meaningful and valuable advice, honestly. I do have one last question for you. Again, thank you so much for talking to us today about just the history of medicine and where we are going. I do want to ask what kind of book recommendations you have for us as pre-med students.
Okay, that's great. That was going to be my next thing. So my grandmother insisted I take Latin because she thought that would be great for anatomy medical school. Don't do that. She's like, you'll have to learn so many terms. So the first thing you should do, the book that you should read, and I still have it, is there's a book called How We Die. Now, I'm in a field where occasionally people die. Not very often, but there are some fields in medicine where you're not going to deal with that ever. But it's by Sherwin B. Nolan. He died a few years ago. But it's called How We Die, and it's very eye-opening. And I think we learn so much in medicine about treatments and how to live and keep people alive that we don't understand. We don't accept that people die, and how to have people die, as painlessly as possible with dignity, and just to know when to quit. And so it's a great book. It's called How We Die. I can send this. I'm going to send you guys my Word file that has the COVID information on it. I'll send that too. So that's the single best book I would read. There's a book called, oh God, what is it called? I had it written down earlier. House of God. I read excerpts of it. It's from the 60s. It just talks about how crazy medicine was. A lot of people find that entertaining. I don't watch any medical shows. However, no, I should say this. The only medical show I've ever watched, and I've loved it, was Scrubs, because it's actually the most realistic. Now, it's funny, it's a comedy, but when I watched it, it just helped me to get through internship. What I liked about it was a sitcom. It was a comedy. But at some point, I was like, this has to be written by medical students. There's things they talk about that only interns or residents would know about. Well, then the creator of the show was in an interview, And he said growing up, all his friends became doctors, and he became a director and writer and that sort of thing. And so his friends would send him all these ideas. So a lot of the plot lines and the jokes that are in the show are ideas from other doctors and that sort of thing and residents. So I think it's actually the most realistic show, not Dr. House, not Grey's Anatomy, and it's entertaining. So I would read that book. I'd read How We Die, and I'd watch Scrubs reruns, just for stress relief. But find something that relieves the stress. The thing about medical school, and someone told me this, and it was true, is that it's like several times faster. It's so much more information coming at you so much faster. Maybe they do a better job of it now than when I was in medical school, but it's still a lot of information just thrown at you. And there's no time to stop. If you get behind a day, then you're just behind a day for the rest of the semester, it seems like. So you have to figure out ways to, whether it's running or riding a bike, you have to figure out ways to de-stress and to just kind of let those things go. So I had certain habits that really, like I said, even when I was studying, I would take a break and read about, Abraham Lincoln or whatever. So figure that stuff out now before, you're in deep in medical school.
I definitely agree. I mean, like sometimes with the pressures of just trying to get work done, but you're not in the mental state, you end up slowing yourself down more than if you were just to take a mental health day or do something that would de-stress you, like you said. So I think that was a really valuable advice. I don't see any other questions in the chat. So I think you answered everything from our side. So thank you again for coming and talking to us about everything. Really appreciate your time. So do you have any last remarks or anything before we move on?
No, I think it's, there's one question I wanted to ask you all, because y'all were chatting a little bit, I followed a little bit, but what I want to know is how are things for you all as students now? Like, how's it affected your life?
Well, I mean, I think being quarantined, at least for me, has been both good and bad. I know, or at least for me, I've been able to have more time with my family as opposed to what I usually wouldn't had before. But being stuck in my room does get tiring sometimes, and I do find myself losing motivation more frequently than not. But I mean, I can't speak for the others.
Yes, I will say that I am enjoying saving gas. I will say that. I don't have to drive to many places as much anymore. I know with some students it is a little bit harder to get in the mindset of school, like Sneha said, because we are just in one room. It's hard to compartmentalize the different subjects.
Sure.
Also, when you're taking exams, if you're in a place that doesn't have much privacy, that gets rough, because just today I was taking an anatomy exam and my family member came in during the exam and they were doing an online proctoring thing and they saw that and flagged it. So it has its own unique set of challenges depending on your own home life and what kind of benefits you can get out of it based on what kind of resources you have at home.
Right. That's what we're seeing with my daughters. Anyway. I'm sorry, Lane.
No, you're fine. When I was in early high school, or before I got my own apartment and was still living with my parents, my dad used to tell me, he'd be like, "Oh, you're on your phone way too much." And now we're in school where we're literally supposed to stare at our computers for 8 hours a day. And I was like, "No, Dad, this is an educational thing. Like, I'm supposed to do this. I've been preparing for this."
Yeah.
And all jokes aside, I really thought that I would be able to handle it more than I am. But like, it's getting rough. I think, I don't know if the word is like ergonomic stress or something like that. There's a specific word that's like, it's some damage that you can have in the workplace where it's not like, oh, you slipped and hit your head on something. It's you're staring at your computer from the wrong angle. And so your neck is strained and your eyes start to hurt and all of that. I can't think of what the word is, but like, that's a thing. And I am not as young and spry as I used to be.
Well, you heal quickly, trust me.
I hope so, but like, I don't know. I miss being able to like go out and walk around and see people and see the sky. Like I've had 2 tests today, and so I've been looking at my computer all day, and I'm gonna go outside and I'll look on my patio and I'll look up and then I'll go back in and I'll have another meeting in an hour. it's just a lot of staring at one specific thing.
Well, I'll just reiterate that everybody's going through this, right? And when I mean everybody, I mean everybody. Mexico, India, other countries, it's affected every wealth level. You know, you can't be too rich for COVID. I would always encourage you all to find some way to leverage it to your advantage. So last week we're doing a virtual for the semester, right? We just decided we want something consistent, but we don't want to have to scramble when they shut the school down or whatever. So we have a vacation house in Austin, which is nice to have a vacation house in Austin. But that's because I've worked and saved for many years too. So we like to go there on weekends. Well, I had a week of vacation, and so we spent the entire week of vacation in Austin. So I was my daughter's teacher, basically just a proctor. Like I made sure my 7-year-old stayed on task. And then at 3 o'clock, when we were done with class, each day that I was on vacation, we went to a different state park or different lake and went swimming. And my wife and I had been kind of complaining about, the online learning problems and, this app doesn't work that well. And I said, that be that as it may, it's pretty cool that we can just travel and still be in school. Like, this is pretty nice. So I don't want this to go away quite so soon. But like I was saying earlier about how it's sort of pushed through all these things that we've been advanced for. One thing I forgot to mention was telemedicine. For years and years and years, the Texas Medical Board just dragged its feet on telemedicine. And because of this crisis, people can see their doctor from home. I have a friend that, we're talking about being lucky, he's an ER doc. He quit his practice. He was in a group practice. He just was fed up with it, just like left in November. This is before COVID, right? And it maybe seemed like a bad mistake. He's like, I'm just going to do concierge. I'm just going to do telemedicine. Actually, he wasn't going to do telemedicine because it wasn't really that available. And basically, telemedicine opened up. Now all he does is he goes to, like, he's gone to this cabin that he and his wife rented for like a few days. They're out in the wilderness or whatever. He's got a good Wi-Fi connection, and he's seeing patients through his laptop. And so now that's great for him. But I think it's great for patients that have like mobility problems. They have transportation problems. I work in the Parkland Anesthesia Pre-Op Clinic, and the last meeting we had, I was like, why are we even seeing these patients? Like, why are we seeing them in the clinic? They all have cell phones. And so that's actually the next stage, is that we're going to start doing telemedicine as much as possible for a patient population that sometimes has 2 or 3 appointments in a day, and they have to get around by bus or by DART. And so you're making them kind of run all over the campus when they could do it all from home. I don't have to physically see patients and examine them. I can look at their airway, and that's pretty much it. I don't absolutely have to, lay hands on them. And so, but when COVID goes away, my expectation is that these things will stay in place, right? So Lane, I would encourage you to get outside more, get some vitamin D exposure, but really just this is the time now to find the things that do help you relax. Because I will tell you, I know it sounds maybe surprising, but I have colleagues that are my age, they're in their 40s, and they did what most people do, which is they're pre-med and they're medical students and they're residents, and they just kind of put their head to the grime, and they really don't have those coping mechanisms that I was lucky to develop. I just had smart people tell me to do these things or whatever. Just the fact that people pointed that out was helpful. And so there are literally people my age and my generation that they just didn't develop that. It was always kind of on the side because it was each little goal and step was more important, and they really neglected that side of themselves. And so I'm happy to have some hobbies that I enjoy. I was mentioning earlier, I do the model cars. Well, my 8-year-old abandoned me. She doesn't want to do it with me anymore. But so I build these little model cars. Yeah, I know. I build these little model cars by myself when they go to bed. But it's kind of a fun hobby that I've like reignited from when I was a kid. So thank you for your time, everyone. I'm hoping that this time next year, if we can meet in person, or even if we can meet in person, I may still do Zoom because that'll save me a trip to Richardson.
Right.
No, I like your campus, and you guys were very welcoming last year. So I'll be happy to do it again next year, and I'm sure a lot will change between now and then. I will send you my Word file on COVID, and then the reminder for the name of the book.
Awesome. Yeah, and we'll definitely pass those on to the rest of our members. But thank you so much for talking today, and we'll go ahead and get started with the rest of our meeting. So thank you again.
Thank you.
All right. Bye. All right. So I'll go ahead and share the rest of the PowerPoint, and we'll make sure to go through these pretty swiftly so you guys don't have to stay longer than necessary. Can you guys see the PowerPoint?
Yes.
Okay, sorry, one second. Can you guys see this?
Yep.
Okay, cool.
Yep.
I'm gonna take
Okay. Should I go ahead?
Yep.
Okay. So hey guys, I'm the volunteer coordinator, and so I found some pretty cool virtual volunteering opportunities, just like online. And so we start off with. So the crisis text line has been a pretty good opportunity for some people, but recently, if you log on and you check it out, it's closed because they have enough volunteers. So this is a great alternative, 7cups.com. It's essentially the same thing. And then you have Upchi for low-income tutoring around DFW. You have Do Something and Om Prakash. These are both databases of online volunteering opportunities, which are pretty cool. Can you go to the next slide, please? And then other than those volunteering opportunities that I specifically highlighted, there, if you check out our website or our link tree on Instagram and Facebook, there we have like a whole database of virtual volunteering opportunities. And then we have some cool collaborations that we're going to talk about in the next few meetings with like Brain Exercise Initiative to work with hospice patients or people with Alzheimer's. So keep coming back if you're interested in any of these. And then finally, keep in mind that none of these events are actually mandatory, but we're keeping track of who participates in both meetings and AMSA events. And these people will be first in line for any cool clinical opportunities that we're able to secure. That's all for me.
Okay, hi, I'm the clinical outreach coordinator. And so this semester, obviously, because of COVID, access to clinical type opportunities is going to be greatly reduced. Like all the hospital volunteering programs are mostly gone. So there's different opportunities that have come up as a result of this as well. For example, a lot of the research conferences that would normally take place in person, that would be basically impossible for you to attend, are now online and you can actually show up. So these are opportunities to meet researchers, learn about their work. You can watch poster presentations and you can ask questions directly to the people that are heading some of this like really interesting research. And you can develop relationships within those types of communities if that's something you're interested in. So on our website, amsautd.org, if you click to the opportunities tab and then click research and clinical, you'll see a list of, I think there's 11 virtual conferences that are now fully online. All but one of them is free. There's a wide variety of topics there. There's one on COVID, there's a couple on neuroscience, there's a couple on AI and neuroscience, there's a couple on plant biology, there's some in ethics in medicine if you're interested in bias in medicine. And so you're free to totally attend any of these. The brief descriptions and links to register are all included on the website. So yeah, good luck.
All right, guys. So I'm Shruti, I'm the treasurer. Something that we like to do in our AMSA meetings is kind of talk about what's going on in the medical news. So if you've been following the news, you've probably heard of the race against time to develop COVID vaccine. Now, this process generally takes a couple of years because there are a number of stages ranging from efficacy to safety to making sure that the effects of the treatment don't cause any side effects in patients with pre-existing conditions. And quite a few companies want to finish up this entire process and get their vaccines out by the end of the year. So AstraZeneca, which is a company that's trying to reach this end goal, around the end of last week during their phase 3 trials, one of their test subjects developed a neurological problem, transverse myelitis, and they decided to pause their trials. So some questions to think about include, is it worth it pausing a trial in the middle of a pandemic when so many lives are at stake? And then in general, the whole concept of like compressing this vaccine development into the span of a few months in the middle of a pandemic. Could we move on to the next slide after this one? So this article delves into the fact that systemic racism is receiving a lot of coverage. And the unfortunate reality is that seeped into academia and medicine. And when you look at COVID-19, you also see that it has disproportionately affected members of minority communities, whether it's because of genetics or it's because of the fact that, a lot of members of minority communities tend to be essential workers, is something that needs to be researched. So some questions to think about include ways in which we see systemic racism in medicine today through, patient treatment and medical care. And going off of that, do you guys think that, medical schools have a responsibility to sort of combat this problem? These are questions to think about.
And if you guys have any comments or any thoughts on these, feel free to unmute your mics and just speak up. All right, Lane.
Sorry, my thing was muted. Hi, I'm Lane, I'm secretary. So another thing that we like to do at AMSA is have ethics questions during all of our meetings. So these are types of questions that might possibly come up in medical interviews, and they're just things to sort of make you think about what situations are, or what things that you would do in specific situations that doctors have to face. So for this week, our question is what we see up here. So basically, you have two patients who have both been admitted after a serious accident. One is 20 years old, the other is 60, and you can only save one of them. Which life would you save? And there are several different factors that could go into either of these. So for example, you could say, oh, the 20-year-old is young and spry, as we established that I am not earlier. So they're young and spry, and they've got their whole life ahead of them. And they've got so much other stuff that they could do, so we should save them. Or you could say that the 60-year-old is well established in life. Maybe they're a grandparent, maybe they're also a doctor, maybe they're well established in their career or some other part of life. We encourage you to put, as Sneha just said, we encourage you to put your answers or just your initial thoughts into the chat. I don't know if there's specifically a correct answer for these. It's more just, what do you think you would do in the situation? I think we can go to the next slide.
Okay, so now that we've gotten to the end of our meeting now, I just want to say hello. Thank you guys all so much for being here. Make sure you follow us on all of our social medias. We will be sending out these slides in an email after the meeting. And the QR code is for the sign-in, and I will also drop the link in the chat so that you guys have easy access to that. So if you could please fill that out, that would be so great. And make sure that you check out our new website. We worked really hard to get that up before this meeting, and it has a lot of really great resources.
Sorry about that. Here.
Oh, you're good. Yeah, so please stay connected with us. If you guys have any suggestions, let us know. Any collaborations or like awareness advocacy work that you are interested in, please let us know. Reach out to us on any of these platforms. We really want to hear from you guys. So,
if you guys have any questions, we'll hang around for about 5-ish minutes. Oh my gosh. So yeah, definitely unmute your mics, leave questions in the chat, or do whatever you need to do.
Sneha, would you like to discuss our ethical question of the week?
Let's see, let's go back to that. I think if I were to look at it at first shot, I would probably take into account family that they have around, if they do have like a bigger, like how big their support system is, based on like who comes and visits them at the hospital, kind of their age is a factor, maybe their quality of life as well, because I know that's a big factor, you know, if one person is kind of barely staying alive just because of like an IV or something like that. So those are just a few factors that I would take into account, but I for sure couldn't say anything unless, or I for sure wouldn't pick something right now unless I took into account those factors. But those are just some things that I would think about first. Do any of the other officers or any members have any thoughts about that? Stephanie, maybe?
I kind of think that with it being, what is it? So with both of them requiring like immediate attention, so like if you have to pick one between the other, then the only thing that you can really say about them is, I mean, I guess you could take a history and see what their kind of, you could see what kind of life that they've led, as you were saying earlier. But with that, you could sort of, I don't know if you necessarily want to use that to judge how much they would get out of continuing to live. And it's a really, really fine line to go, because of course you don't want to have to like pick between who gets to live and who gets to not live. But I really think that we should consider, sort of, as you were saying, what types of stuff that they have established and like how they lived beforehand. So like if this is a repeat thing, then one of the people has consistently done this, then, and the other person has like a family and they have a job and they have all this other stuff, then maybe we should consider the other person as opposed, or maybe we should consider one as opposed to the other.
And I will say one last thing about this case, because they are coming in, it could be a first come, first serve basis. So if you look at emergency situations in terms of triage, there's 3 different types of triage that you would assign a person. And it's on the levels of, I don't quite remember it fully, but it's green, red, and black, I think is the one of them. And so I know I'm missing one, but I am not an EMT. I don't know all of the things that go into emergency medicine. But based off of that, then you are to quickly assess both patients, especially if they're both coming in at the exact same time. Triage them fully based on a quick general examination of both of them, and that usually is done by the nurses in the triage area. And then after that, then you'll have to make the final decision based on what everyone else has talked about as well, including the social aspects, the issues that they might be involved in, and the time course. So yeah.
Awesome. Yeah. So there are a lot of factors to take into account. It isn't just simply their age, as people would commonly probably lean towards. But on a side note, our sign-in form is fixed. It's in the chat. So if you guys want to go in and sign in, that's how we're going to kind of check attendance and kind of see who's been attending our events. But if you guys have done that already and don't have any other questions, you guys are free to go. But thank you so much for joining us on our first virtual meeting. It's been a complicated and very different semester. So thank you guys so much for dealing with the changes and still being a part of AMSA. We really do appreciate it. So thank you guys.
And please stay tuned with our social media and email list. We do have monthly meetings, so we will have another meeting next month. So once we get the date situated as well as the time, then we will update all of you guys, and I hope that you join all of us then.
Bye.
Thanks, guys.
Thank you.
Thank you.
Thanks for coming.